First of all, I would like to say a few words of thanks to the organizing committee for this marvelous opportunity to present the results of our study here in Lissabon. There are no potential conflict of interest in the report. Every one of us who have ever been faced with results of car accident have no hesitation about this statement. However, there are a lot of questionable statements. What is the preferable way to manage rib fracture, especially in case of combined trauma? Our aim was to compare long-term outcomes of different rib fracture stabilization methods for patients with combined craniothoracic trauma. This flowchart describes our investigation design. We divided whole quantity of patients into parts. One of them underwent surgical stabilization in two different ways, whereas the second one was stabilized pneumatically by artificial ventilation. Next few features present an example for methods of operations. Patients who met such criteria were excluded from the study. To evaluate trauma severity, we used traditional scales. Pain syndrome was assessed by providing both visual analog scale and behavioral pain scale for unconscious patient. Ventilation function was evaluated by assessment of traditional indexes, and health-related quality of life was used to compare results on the long-term outcomes for the life quality. Both groups were representative and comparable. We have no goal to compare different kinds of surgical procedure. However, we achieved only one difference in the time of operation. Intramedullary osteosynthesis was considerably longer time. Although in the rib cause formation in the term of 30 days after trauma, we found statistically significant deviation between the surgically stabilized group, whereas there was just only 10%, around 10% of patients have no rib consolidation, whilst in the second group, more than 1/3 of patients has the same situation. Next two pie charts describes dynamics of rib cause formation in the second group, the 60th and 90th day after trauma. At the same time, in the group with surgical stabilization, all the patients have complete rib consolidation. Next few images just to prove visually all percentage presented before. We found that there was statistically significant diminution of pain syndrome intensiveness in the group after surgical stabilization, as well as we found that long-term impacts on ventilation function. There was statistically significant faster normalization of both indexes as total lung capacity as well as VAV for the first second. These two effects have resulted in improvement of user health quality. We found that climbing of health quality in the group of surgically stabilized patient. He is presented post-operative mortality and morbidity, and indeed there was significant difference, statistically significant difference in air leakage and pneumonia frequency in the groups. To summarize, it is crucial to say that the use of surgical stabilization methods permitted to speed up the consolidation process to achieve faster ventilation indexes normalization and to improve health-related index of quality of life on 0 to 3.5 points. Thanks for your attention.
May I ask to show the slide with the presentation of the technical method? Can you explain it a little bit more, because it's not widely used? This
Okay.
is the problem.
This one, please.
No, this one is this one.
Here present a case of patient with combined cranio-thoracic trauma who have flared chest and contusion of brain, second stage as I remember. Here we provided fixation of the flared chest by insertion of the screw to the novel fragment, and the other one was fixed to the stable part, and we controlled by thoracoscopically location of 3 fragments and their stability during breathing. All the screws are fixed by the splints on the external metal bar from the steel. And this technique is performed just through the 2 small incisions to make approach just onto the bone to make insertion of screw. This construction is used just for, typically we use it for 2 weeks, around 14 days. After that we take it out.
My short question, how did you measure the visual analog scale on the patient who are on ventilator?
We used for this purpose, thank you for the question, we used for this purpose behavioral pain scale. It's very comparable to visual analog scale.
The paper is open for discussion. Any questions?
Can you also arrange the, can you also apply retraction or closure of this method with this new method? Or is this a fixed method that you kind of fix the 2 sides and it stays like that? Or you can, if there is any displaced rib, you can move it to the side?
It's partially fixed method because you, in any time if you find any complication, you could move bone fragments one to each other depending on their location in case of displacement. But it's a 2-round case.
Gilbert Franscheid from Germany. I think, how many of those patients have had lung contusions? How many of those patients needed an operation? How many patients have had instability? Because this, I think I want to have it, it looks very interesting, but I want to have it a little bit more precise when you see the indication.
Thanks for your question. Firstly, in case of flared chest, there are no doubts in this case. We try to fix in such way. It's one of the preferable way due to today's invasiveness, and actually for the 3rd class by Oxford classification rib fracture, when we have more than 3 rib fracture with bone displacement, we also try to perform such manipulation. For sure, we don't use it for severe brain trauma. We exclude this patient from the study, and we haven't present. As I remember, if you will say what is the quantity of brain confusion, it was about 50% from the whole group. And the indication, most of the indication is caused by current chest stability.
Some more comment?
You stabilize it from one side to the other. One is the fixed part, the other one is the not fixed part. The mechanic of the thorax is when you inhale artificially or normally, you fix it, you should have a restriction. With that, I fear, but maybe you have other experiences.
To be honest, we haven't connected with such situation. Possibly it would be a restriction. We will try to, in case of such patient, we will decide on precisely. But we have to discuss this. Thank you.
Any other questions?
No, thank you very much for your presentation.